Hello, my name is Stephen Patuan, and my presentation will be about increasing patient access to care in nuclear medicine using fundamentals from Six Sigma and Lean. Alright, so a little bit of background about the project and nuclear medicine. I currently work for a hospital located in Washington State as a paramedic for the nuclear medicine department. Nuclear medicine is a type of imaging department where we use a small amount of radioactive material, which is known as technetium-99, and that's a nuclear isotope, and we use that isotope in conjunction with a specialized camera to do images inside of the body. These images provide information that cannot be obtained without a nuclear isotope, such as a CT scan or MRI. Those are different types of scans, and help us to diagnose different disease processes in the body. As a part of nuclear medicine, we do many different studies and exams to examine how different organ systems function. These different organ systems include some gallbladders, your kidneys, breasts, obviously in women, gastric emptying studies, which is kind of going with your stomach and your intestinal lining, and cardiacs. So cardiac testing is my specific role in the department and where I wanted to make the most change in our workflows. With that, I will explain our cardiac testing. The test typically takes between 3 to 4 hours, so pretty long test, and that's per patient. And it starts with an IV being placed and then an injection of our nuclear isotope, that's the technetium-99. This is a highlighting agent that allows us to see their blood flow under our camera. We have them wait for about 60 minutes where they will then undergo a scan under our special nuclear imaging camera. This machine essentially looks like a CT scanner if you've ever seen, one like that or ever done a CT or MRI. It's pretty similar. The scan takes approximately 10 minutes where they're then put in a room and they're either going to walk on a treadmill to get to a certain heart rate, and that's based off of like age, or it can also be per gender, stuff like that. And if they're unable to walk on the treadmill, they're given a medication, and that kind of simulates the exercise in a sense while they're laying down. And that's mostly for people that are, unable to walk up hills, unable to walk long distances, disabilities, any reason like that. After this portion of the test, the patient will wait 45 minutes and undergo another scan under our imaging camera, and that's the end of the test. So as you can see, this is a long and complex process. As such, our availability has always been limited, and in the past we have typically only managed to see 6 to 7 patients a day. So that is a problem. Only being able to see 6 or 7 patients a day is not great access to healthcare. As we know, though, healthcare currently has many problems, and one of those largest problems and greatest challenges that we're facing in healthcare is the lack of access and a lack of appointments for patients. This leads to extended wait times for patients, which will also lead to frustration from these extended wait times. According to Jack Levitch from the Association of Healthcare Journalists, the average length a patient waits to do an outpatient, non-urgent study is about 44 days, and that's not specific to nuclear medicine, that's just the average wait time for any type of non-urgent exam. But that's almost incomprehensible. How are we waiting or making somebody wait 44 days just to be seen for a study? I understand this is a non-urgent study, but many times these non-urgent matters can quickly become urgent. And especially in nuclear medicine, whenever we think of the heart, that we're testing through these cardiac exams, it feels urgent to every patient, and it feels urgent to us. I mean, you're not getting a nuclear cardiac exam just for fun. This creates another problem by adding a solution, as the only solution that we've seen is to have the patient go directly to the emergency room, and they'll be put there and then get pushed into an inpatient slot in our nuclear medicine department. But this puts unnecessary strain on the providers in the hospital, and it can also tie up a much needed bed for other patients that are there for an emergency and not so much to be seen sooner. In nuclear medicine, we are a shorter wait time than the average of 44 days, but we are still at an average of 36 days for a patient to be seen for an outpatient nuclear cardiac exam. So these are some of the problems that I've identified, and now I want to talk about some of the solutions. Now the solutions are where Six Sigma and Lean are going to come into play. Six Sigma is a strategy used to identify flaws and reduce process errors, and that's from Bolin. Lean is a process used to identify and eliminate waste, and that's from Yoon. These are both processes that we covered extensively throughout the healthcare management and leadership program, and I wanted to take my knowledge of these concepts and apply them to this project. As I broke down earlier in the presentation, patients do start with an injection of our isotope. They then wait about 60 minutes to let it circulate throughout their body. Then they do a scan under our nuclear imaging camera. After that, they do the stress portion, which is where they walk on the treadmill or get that medication to kind of simulate exercise. After that portion, they wait 45 minutes and they do another scan under the camera. We saw here that there was a lot of waste in terms of employee downtime and a flaw in our system with having patients do a rest injection and a rest scan. We decided to cut out the first injection and the first scan and only do the stress portion of the test and the stress scan. This freed up approximately 1 hour per patient and gives us less overlap of patients that need to be scanned at the same time under our nuclear imaging camera. We only have one camera. By having less overlap between patient scans and less time patients need to wait, we were able to add on 3 more patients per day. And before this change, we were seeing, around 35 to 40 patients per week. And that's counting, we do get some inpatient orders as well. And now we're seeing, around 50 to 60, so a pretty good increase. This might sound like a small change, but this has greatly increased our access to care for patients, and it's decreased the patient wait time significantly. We went from an average wait time of 36 days down to just 19. We've also decreased the overall time that patients will be doing testing, making them happier while still getting the same results. The only other change this has caused is that if their stress scan, which that is the scan after receiving, the medication or walking on the treadmill, if that scan's abnormal, they just come back the next day to do the rest injection and scan. So they would just be getting, the old test essentially at that point. But it's super rare for these studies to be abnormal. Many times if they are abnormal, they are set up for a cardiac catheterization anyways, and that's where they, go in through the leg or the wrist, and they, put in stents, stuff like that, so kind of more definitive than what we do. And we rarely have it done to where they need to do the rest injection and scans the next day. So in reducing waste and employee downtime and process errors in the delays of care, we've been able to increase our revenue and increase the number of patients we see per week. So let's look at some of the results in a way of numbers. So we do have to pay for our isotopes, and we do get them delivered each day from Spokane, Washington. They have to be driven down to us, so kind of a taxing effort. Each patient does require 2 isotopes, so one for the rest injection and one for the stress injection. Each set of these isotopes costs around $80, give or take, a few dollars. And in 2024, this made our cost of isotopes approximately $142,000 for the year. But since our change, patients are only receiving 1 dose of isotope, but we are doing more patients. So for the last 3 months, we have spent a little under $40,000 for the year. So the projection is going up in cost spent, but we are seeing more patients daily and weekly, and so that's kind of a positive. All right, looking at patients per year, like I said, before our change, we were seeing, around 35 to 40 patients a week. This resulted in seeing, around 2,100 patients for the year of 2024. But with our change of seeing around 3 more patients each day, in 2025, we are projecting to see over 2,700 patients. That is over 600 more patients in a calendar year just from changing one process and reducing some waste. All right, so looking at the revenue, it's pretty staggering. Nuclear medicine, it's a very profitable portion of healthcare. And in 2024, we saw a revenue of, close to $7 million. Since our implementation of changing the way we are scanning, see more patients, we have made revenue of a little over $2 million. And with that data in mind, we are projecting to make a little less than $9 million. And that's just from changing some processes and increasing just a few patients per day. But it's all adding up in the end, of course. Alright, so overall, we changed our workflows from doing 2 separate scans and injections to only doing 1 injection and 1 scan. This allowed us the availability to add on 3 patients per day for cardiac testing, and with adding 3 patients per day, we are going to see significantly more patients in 2025 than we did in 2024, and we are going to see a massive increase in revenue as well from 2024 to 2025. In seeing more patients, we are reducing wait times for patients and increasing access to care for these patients to come have important nuclear cardiac exams done. And this has all been spearheaded by reducing waste in the department and getting rid of unnecessary scans while also increasing our process improvements. Here's my reference page, and I hope that everybody enjoyed the presentation.